examination which were done today. So I have those results, but I'm not sharing it with anyone. So I'm very grateful to all the panel of judges led by Dr. Santini, who have listened to all these talks and have the question and answer sessions with them. Can I request Dr. Anders Stallman and Dr. Sebastian to be the moderator for this session, please? Yeah, thank you. Anders, I hope I'm not disturbing you. You were on your laptop, so thank you. So let me start our last session for the day, and it's all about ligaments and the patellofemoral joint. The moderators are there. So let me invite Dr. Mustafa Javed to tell us about the radiological planning for all the osteotomies. Thank you. So, Mustafa, over to you.
Thank you very much. I'll just get straight into it. These are, so we got the screen up. So Ijaz and Faisal, we were discussing that in this talk, we'll have quite a lot of overlap. So I'll probably try to whiz through this, and there will certainly be some overlap. So if you talk, these are my disclosures. So if we talk about a quick review, so we're going to talk about the axes, which are mechanical as well as anatomic, a deviation from these axes, and the normalcy of joint angle. So we'll be talking about those. But just realize, at least in Pakistan, we won't have these lines or angles, at least. In the OR, you may have computers, but you may still have to do a few things from your head. So the hull deformity team and my trainers, Hemant Sharma, Liz Mulder, and partly Adrian Wilson, the chats that I've had with them has simplified things for me. And that is measure the deformity, analyze the joint angles, and pick the deformed bone. So map. You got to ask yourself, where is the deformity? Where should I cut the bone? And how am I going to correct the deformity? So find the apex. So they will all have an apex, but just remember that they may have more than one apices. How are you going to cut, and at what level you're going to cut, and that'll depend on various factors, including skin conditions and other mechanical factors. And then decide how you're going to make a cut and how are you going to fix it. So what you're looking for is finding the center of this deformity, intersection of the proximal and distal axis. The angle formed is what decides the magnitude of deformity, and that apex will guide you towards correction. So just remember, for me, as to keep it simple, every segment has its own axis. So no matter what size of the segment, it will have its own proximal and distal axis. So how do you do that? So you've got a certain deformity like so. So you make a line above the segment and below the segment, and in the center you'd most probably get the apex, and that is where you'll define the correction required. So how do you identify the axis? So simply putting it, you'll have the mid-diaphyseal line. If you have a normal joint angle, that is of your own benefit. And then you're going to be using the normal bony landmarks, which is the normal bone segment above or below. So how are you going to choose the level of osteotomy? The apex is the ideal location. You would realize at some points it is very difficult, and you may have to choose anything other than the apex, and then decide what technique of osteotomy you're going to use. The rule, you're going to make the osteotomy as close to the apex as possible. If the osteotomy is closest, the alignment is perfect or near perfect. But sometimes that may not be possible, and you then need to make obligatory translation, and that offsets bone margins. So here again, we've taken the proximal segment, the distal segment, we've found an apex, we've performed an osteotomy at that level, the hinge is at that apex, and you perform the correction. With the correction, so again, you've got this image where we've taken a certain axis, the mechanical axis, and a mechanical axis from the distal segment. I wouldn't say bones, but I'll say segments, and that helps us decide that we've got an osteotomy or an apex level, and then you do whatever correction and whichever way you would prefer to do so. And to achieve normal joint angles. And that is the distal femoral angle nearly to near normal. So what you're doing is you're recreating what you've decided on the x-rays outside in your clinic. You've planned your joint angle, and you're going to predict if there's any translation that is required. But keep remembering that, I wouldn't have these lines whilst I'm in the operating room. So what would you do here? So you've got a 45-year-old manual worker, it's got medial OA, you made your lines, you made your angles, and you've done a certain form of correction. What you need to look at is, where is the deformity? Is it in the tibia? Is it in the femur, or both? What axis are you going to choose? What kind of correction or implants are on offer, and whether or not you're going to use bone substitutes? So we've got standing long length views. I hadn't had the luxury of having these till I've recently joined an institution, so I'll have more of these. So you will certainly need these standing long length views. These dreaded lines. So, I always forget, so I have picked and chosen what I would want to use. So what I do is we get a mid-diaphyseal line, we get a second mid-diaphyseal line, we get an angle, which we know is within 0 to 2 degrees. We're going to start making angles. So I like the proximal tibial angle, which is near 90. 9 less is the anatomical lateral distal femoral angle, and it's easy to remember the joint convergence angle. So eyeballing all of this, you can get a low MPTA and a reasonably normal LDFA, which tells me that whatever I'm going to do, it'll probably be in the tibia. So it gives me a ballpark figure to start working on things from here onwards. So again, the images aren't that great, but so where would the deformity be? So we've now got a lateral distal femoral angle, which is high. The joint convergence is high as well. And we've got an MPTA, which is low. So which means that there's a lot of correction that needs doing. So you'll start thinking that you would need to do multi-level osteotomies. So these are just general ideas that need to get through things. Now, if you were to use anatomic axis, the normal femorotibial angle is about 5 to 7 degrees of valgus. We aim to correct 3 over, and this long length view, the angle that is made is about 6 degrees, so 6 plus 7 plus 3, you're still looking at a high valgus correction that you need to do. If you were looking at mechanical axis, Bashir was talking about this fantastic. So if it's the normal, you've got about 2 degrees of varus. The load is mostly on the medial side, less on the lateral side. If you go dead center even, then there's 60%. And as you increase the valgus, you're offloading in a certain percent to about 6 degrees again, which is about 40% off the medial and more load on the lateral side. Hence the thought process that 4 to 6 degree valgus may do the trick. But then that became quite confusing, and hence the reason that the Fujisawa point came in. And what it decides is a certain point which could be of reference. It isn't being used all that much anymore. So I've dropped a plumb line. Then we've taken the Fujisawa point. So from the head to the Fujisawa, and from the Fujisawa down. And that angle that is created is the desired angle of correction. And the rule of thumb being the first 10 millimeters, every millimeter is a degree of correction. More than 10, it becomes a little bit difficult and you correct less and less so. And there is thought processes of using fluoroscopy and computer-aided navigation. So what about bone grafts? So this is a lady, she's a widow, she's a teacher, and she's got children, and she can't afford a joint replacement, either partial or not. And what we've done is we've done an osteotomy. These were earlier versions where the screw angles, the trajectory of the hinge screw has certainly changed in my practice. But what ended up seeing is that in 3 months' time, she starts developing some bone, so not necessarily requiring bone graft. And we don't have osteotomy-specific plates available to us. So I'll whiz through this again. So a girl who wants to get married, she's got a curve in her spine, she's got a curve in her leg, and she wants this mostly for pain, but mostly I think for cosmesis. Adrian Wilson helped me get these softwares done, which I didn't have at that point in time. So again, the lines are, I use ECG electrodes for the center of the head, the center of the ankle, and whatever correction I've done to try and get it in, trying to get it in a certainly offloaded position. So this is the girl when she's walking. She doesn't like it. It hurts her. It's very hard for her to tell whether it's the back or the knee, but she certainly doesn't like her leg the way it is. And this is 3 months after she gotten married, and I think about 5 months after the osteotomy. She likes her appearance. She's expecting and doing reasonably well. So in summary, you're planning for the right patient. You need to know where the deformity is, what axis you've chosen for yourselves, what degree of correction you're going to plan, the implant, and whether or not you're going to use a graft. Thank you.